at this conference. Probably I'm the only nephrologist here, but I want to assure you that my divide it into two parts. One is I will review what's the story of chronic kidney, of the combination of chronic. So the Kidney Disease Qualitative Initiative simplified our business, and almost so this slide tells you what's happening with the PACE study. And this comes from National Health and Nutrition Survey that's done periodically. And you would be surprised to know that chronic kidney disease is worse than most. And here's another study by Foley that opened our eyes and showed that so what's going on? There is some sketchy data that we have. And that shows about target organ damage, that shows up. And Alan Go, a few years ago, presented an elegant study. And we also know that it's not just the traditional risk factors that you see in your patients with cardiovascular. Before I go on to review the 4 papers that I mentioned to you, I want to urge you to just listen to this, see this slide, because I frequently see cardiologists take serum creatinine as their number and decide whether this patient has CKD or not. And most of the time, most of the lab, the normal range, the upper limit is 1.4 to 1.5, okay, which is not right. You have to see. Here's an example. If a patient is a 24-year-old black, and this comes from, this data is from the US. If a black patient has 1.3, probably he has stage 1 kidney failure. But if a white patient has 1.3, he is already in stage 2. Okay, and same with this. Another important thing that I would like to mention to you was it's not just the creatinine, it's also the albumin. Like now. Coming to the update, I selected 4 papers. The first paper was published more than 16 months ago, and that those who were stone formers had high traditional risks. Okay, they were for all other risk factors that we just mentioned. There was still 31% higher incidence of myocardial infarction in stone formers. So this is almost like a hypothesis generating study. A second study, and I think you will hear much more about this, FGF23, in the coming months and years. So the question was, most of the studies, observational studies, have shown that FGF. So what they did was they looked at the CRIC study. Now they looked at the cardiac myocyte in mice, and they injected. They also injected FGF23 in vivo in these. The question was, Clotho was not present. The co-stimulator it's called the PD173074, and they still showed that it can. So in summary, it showed that there is a causal link between CKD and LVS, and there is a hypertrophy. Second study is the ACT study looking at preventing cardio. The results were clearly showed that acetylcysteine does not really help. So, so we may be wrong in using it in prevention of. Okay. So I'll end here, but thank you.